A Challenge to Dignity. Our goal was to link academics, activists, and agencies concerned with the health of refugees and asylum seekers in a spirit of collaboration and comparison, bringing together professionals working with different populations of forcibly displaced peoples, ethnic groups, and nations. The video you are watching will contain all the presentations in one of 5 thematic sessions. We hope you find them to be of value. And our first presenters are Doctors Victoria Ojeda and Jose Luis Burgos. And I would like to briefly introduce them. Dr. Ojeda is, let's see, where is she? There she is. She's professor in the Herbert Wertheim School of Public Health at the University of California, San Diego, and is also appointed in the Department of Medicine at the UC San Diego School of Medicine. Dr. Burgos is an assistant professor in the Division of Global Public Health at the UC San Diego Department of Medicine. The title of their paper is Understanding the Health of Asylum Seekers, Refugees, and Migrants through the Lens of Student Interns at a student-run free clinic on the US-Mexico border. Vicky and Jose Luis.
Thank you very much. Thank you very much, Dr. Csordas. And it is a pleasure for us to participate in today's conference and to talk about our qualitative study on the impact on experiential learning in Mexico among students in their understanding on vulnerable migrants' health. Okay, so let's start the presentation. Okay, so how do I move? Oh, so experiential learning can be a significant aspect in allowing or permitting students or for learning about global health. And it's there's a body of literature that has studied the importance of taking information or learning from classroom into experience in order to have students able to connect, have understanding on real life experience on aspects of diverse settings, reflect, and then explore. And this is the study site. So the study site is Tijuana, which is the busiest border in the world, and is a receiving site or main receiving site for migrants, refugees, and deportees, and asylum seekers. And it's and here as we show in this slide, the migration patterns in this region change dramatically and have been changing for a long time. So the specific study site is Health Frontiers in Tijuana, which was started in 2011 in order to bring collaboration across the border and to bring opportunities to learn about migrant health and global health. And here we're showing some of the patients that are seen at the clinic and some of the images on site of the clinic, where you can see a combination of students from San Diego, from Mexico, and also collaborators from both sides of the border and patients. And from this program, we have courses that were created for both university in Mexico and in the US. So it's an equal learning partnership and opportunity where it combines weekly classes with clinic-based activities on the site. And actually, it is a student-run free clinic in the sense that students take care of registration, help clinicians do vital signs, and also shadow and support consultations. And since 2011, we've had over 400 students participate in this program, including a leadership group that formed from students who actually have taken the course or the experience for several quarters, and actually they actually influence or have significant collaboration as far as tailoring the program. So I'm going to let Dr. Ojeda explain as far as the methods.
Great, thank you. Thank you. It's nice to be here with you all this morning. So we conducted a focus group with some of the students that have participated in the Hfit internship program. And our goal with these focus groups was really to learn how this experience has supported their understanding of refugee, migrant, and asylum seekers' health. And in addition, to understand how participating in Hfit has supported their professional development. Many of the students in global health programs and are interested in pursuing health professions careers or careers in research and academia. And so that was our goal, was to elucidate those particular areas of the contribution of this internship. So this year in March, we conducted Zoom focus groups with 27 student interns and members as well of the leadership board. And we recorded the focus groups, transcribed them, and analyzing is the thematic analysis. And so we'd like to present some of the results today. So on average, the students were 23 years old, and primarily female with 82%. Interestingly enough, Latinx students represented nearly 2/3 of our participants. And similarly, 2/3 were first generation students. And you can see on the right side of the slide that half of the students had the opportunity to participate in person. That was sort of pre-pandemic. And other students, about 1 in 5, participated virtually throughout the pandemic. And 30% were able to engage in multiple strategies, both in person and virtually. And you can see here that, as Dr. Burgos mentioned, Hfit is an opportunity because of its proximity to the UCSD campus and the border that allows students to engage long-term. As a result, nearly half of the students have participated multiple years, and 37% were in the leadership boards. So with respect to what we learned about their knowledge of migrant, refugee, and asylum seekers' health, we found 2 themes emerged from our interviews. In the first theme, we found that some students really didn't have any contact with migrant communities, and as a result, really didn't have any knowledge of migrant health issues. And so those are some of the quotes that you'll see in the top half of the slide. With respect to that specifically, maybe they had familiarity with what was conveyed in the media, but not firsthand knowledge. And they talked about, coming from very white communities and not realizing that there were different communities, different languages and cultures, thinking that Mexico was a community of Mexican migrants that were, transiting to the US. The second theme that emerged was that students had some knowledge, maybe firsthand knowledge, having come from families with migration histories themselves, but they were less familiar with the political, the social context of migration, of the health issues that affect them, maybe lacked some of the theoretical concepts that we study in global health and public health as well. And so through participating in the Hfit program, they were able to, as the second student described, through Hfit, I was able to more formally conceptualize the different issues among this population. So that was very interesting to know. And you can see here, this slide represents some of the students that are out in the field and the kinds of activities that they're engaging with. On the top left, you can see a student preparing for his day in the field and engaging with students, shadowing, taking vital signs, helping to organize the pharmacy, organizing activities for the youth in the community, and even participating with their Mexican student counterparts with guest lectures that we've organized. In addition, we learned that participating in the Hfit internship program raised their specific awareness about migrant health. And the themes that emerged here were that students gained an understanding of the different kinds of migrant subgroups that come to the border that are in Tijuana and just their actual experience. So I'd like to share this quote. I was also around when the Haitians were in TJ in Tijuana. And I remember there's a big difference between Haitians and the deportees, because deportees were mostly men from what I remember. And then with the Haitians, we started seeing a lot more women and children at the clinic, and they have different needs as well. And so you can see this student has had the experience of participating in the long-term Hfit internship and is able to compare and contrast sort of the communities, their needs, and how their health profiles present over time. The related theme was that students' engagement with patients directly and in these different structured stations facilitated learning directly from the patients themselves. And so this student described going to UCSD for undergrad. We would go down to Baja for more like on a tourist basis. Once I got to work with Hfit, you get to talk to these people one-on-one, hear their stories. The complexity of their backgrounds was really mind-blowing. There's so many things that they're dealing with besides just trying to migrate and think about all the health issues that they're dealing with that are stacked upon each other and family issues. And so it completely opened my eyes in like a very humanistic way to what migrants are dealing with. And again, that's one of the goals with the Hfit internship program is to really humanize that migrant experience through direct contact, through stories, through narratives. And you can see the sites that the students are engaging with. In the middle here, we just showed an example of the migrant caravan that was one of the recent waves of migration. And again, that helps to bring it down the news, the media, and kind of dispel some myths that they might be otherwise experiencing. As I mentioned, Hfit supports long-term engagement and understanding of students' health, of migrant health, over time. And so here, one of the themes was that social determinants of health become evident at each visit, and how migrants experience these social determinants of health vary. One of the very positive aspects of Hfit, as I mentioned, is the proximity to the border allows students to walk across the border, experience that migration themselves, engage with the local community and all, the sights, the smells, the sounds that you hear as you're crossing the border. So this student commented, at Hfit, you can see how people who are sleeping on the streets or exposed to the elements really have different health outcomes. And a lot of times what they need in order to be healthy is more social service support outside of healthcare support, right? And so that student has kind of been able to contextualize the role of these social determinants of health, of housing, as part of health needs in comparing, the services provided at the clinic. Another student commented with ACEs, that is adverse childhood effects, and showing connections between childhood trauma and health outcomes was really eye-opening, not only with the patient population. This particular student is actually going on to become a teacher. He had a goal of becoming a psychologist when he first started in Hfit, but transitioned to pursuing now a master's in education as a result. And so he mentioned, I'm going to tie it into my career choice now, like teaching, like seeing students have aspects of trauma in their own lives, how it affects their learning. And that was something that I got from the clinic. And so what we see is a lot of translation from these very specific experiences in Mexico and Tijuana at the border with migrants to other careers, to other populations, but pulling in those academic concepts and healthcare concepts. And students also gained appreciation of cultural dimensions of health. And so this student talked about the clinic opened my perspective on what cultural competency and cultural sensitivity meant, not only in the context of Hfit in Tijuana, Mexico, but applying that to underrepresented groups in California. So again, we're seeing kind of this broader translation and understanding and connection to other communities, underserved communities. I'd like to share as well that one of the goals of Hfit certainly is to support students in gaining that experience of healthcare professions before they pursue their graduate degrees. And we did have information about their personal and professional growth and how the clinical experience ties into that. So we had 5 emergent themes related to professional growth. And students talked about having improved communication and having a better understanding of patient care. And so here they said, Hfit gave me a better understanding as to how personnel in healthcare can approach people who are from migrant backgrounds or from different backgrounds from ourselves to really help understand a little bit better where they're coming from. And again, I tie that directly back to that personal engagement that they're having on a long-term basis. They learned about collaboration and teamwork as being important for not only their activities at Hfit, but for their future careers. So this student cited being that in the leadership group, they were able to collectively work together and help people. We're able to learn together as a community because we're able to communicate with more people because we're able to stay there a little bit longer and we get to know everybody. So there's a lot of peer mentorship that's happening and growth of a community. And students learned about healthcare administration, and we saw that some students had affirmation of health profession as a career choice. So Hfit, I guess, more so reaffirmed my goals. I was pre-med and now I'm pursuing MD or OD, and Hfit reaffirmed my want to go into family medicine rather than going into a specialty. And that's also very interesting because what we see is that exposure to working with underserved populations means that potentially we're helping to build that pipeline for primary care as well. We saw students pursuing new careers as a result of participating in the internship program. And I've given some examples here, which is research, master's in public health, nursing, teaching, psychology, and for some students, gaining a passion to go to medical school. So this student juxtaposed here that they always intended to go to medical school, but now they're realizing that they would like some time to focus on disparities issues. And so she said, the students stated, I might get my master's, I might do research full time, but something along those lines, because it's still really interesting to me. So again, having the opportunity to really concentrate in depth has also supported growing the research pipeline with Latinx and first gen students who were predominantly in our student population. 8 students find that they're building community and they're finding alumni and colleagues in the field. And that's also, I think, very gratifying, as I mentioned, having a community of Hfit alumni. I mentioned that we have over 400 alumni, and they talked about being part of the leadership group gave me a sense of community, to be part of something. And they gave me very useful advice and someone to lean on for support, as and the rest of this quote talks about how that student was preparing for graduate school, and so being able to get feedback from other students in the field. But I just came across a student yesterday, actually, that just got hired onto a community clinic here in San Diego that I'll be able to work with. So, so there are a lot of sort of professional benefits. And this slide here, that you could see that for in terms of their current academic status, we did have almost half of our students in undergraduate, but 1 in 5 were med students. We had a PA, and another one that was in Masters of Public Health or preparing for medical school. And then those that were working in health professions. So that was very interesting to see. And again, here's some examples of the kinds of leadership activities that students undertake, which range from fundraising to meeting with funders to doing outreach and promoting of the clinical internship. And I'll let Dr. Burgos talk about the virtual internship that he organized during COVID, because that was very interesting.
Oh, thank you, Dr. So these are images of when COVID hit and students were not, for safety reasons, allowed to come to the clinic. The program showed resiliency because through the use of Zoom, the use of technology, we were able to continue the clinic. It is a student-run-free clinic. Nobody was hired to do some of the work the students do. So here you can see images where students are doing registration. We had like kiosks where patients would come in, a student would open their files. They would work with the provider. Some of the students were scribing during the interactions. Students were asking and collaborating with psychologists on the field, as far as asking for mental health issues or social determinants of health with the clinicians or social workers, and show a significant, resilience in the sense that the program continued on, and if we go to the current situation now, we're in a combined. We're thinking that we will keep some options for virtual. Right now, we have students from Mexico and from UCSD joining together, and we have students online. For example, in the images, we have a student who he was not in San Diego right now, and he wanted to start a program on relaxation and meditation for lowering stress among patients. And he was able to connect and provide services in that sense.
So in the interest of time, I'll just kind of wrap up our presentation, but we feel that the Hfit program has been a very promising program in terms of reaching and engaging diverse undergraduate students that might not otherwise have access to health focused opportunities, which oftentimes will have GPA or other restrictive financial requirements, and our program kind of overcomes a lot of those barriers. As you saw, Hfit really is experiential learning. They're out in the field. It's a whole person immersion, and students really are able to kind of connect academia with real life issues as they pertain to migration and health. And as Dr. Burgos mentioned, the virtual Hfit program was successful in getting students engaged. However, that immersive experience that is part of that experiential learning process of hearing, smelling, seeing directly, being out in the field, that piece was lost. But there are some benefits to that. And I think, as he mentioned, we will retain some components for students that are not able to cross the border. I think it does allow for their continued engagement. And we do feel that the program is successful in supporting students' pursuit of global health and understanding how they might bring their careers to include migrants and other underserved populations, and also opening their eyes to the role of academia or blending the two, service and academia. So in conclusion, we are very appreciative of all of your time this morning and look forward to your questions.
Questions here? Yes.
First, congratulations to both you, Vicky, and Jose Luis, for your leadership. I mean, you've really taken this from what was a dream. It took 3 years to get this program approved. And it's one of the benefits that I see is that it promotes cultural competency, but in a horizontal way rather than a top-down way, because an organic nature of the program is that the students from Mexico and the students from San Diego really learn from each other. And I could tell from some of the really interesting in-depth interviews that you did that it seemed that Hfit played a role in erasing or minimizing some of the implicit biases that they had. So I wondered if you thought that that was the case, because that just seemed to emerge from some of the themes that you presented. Thank you.
Yeah, absolutely. And, when we talk about the number of students that have gone through the program, those are only the UCSD side. We haven't even mentioned all the side from Mexico that has been engaged. But I think having that close proximity to the community, to other academic institutions definitely helps. But like we said, to humanize and to really allow students to process and to compare and contrast what they're seeing kind of in media and social media to what is the complexity of people's lives. And so that helps, I think, too, like you said, reduce that implicit bias. And it would be something very interesting that we could study and somehow. Dr. Burgos, do you have anything?
And also, I would emphasize, the combination of UCSD and UABC, or students from both sides of the border. We've seen now students that are now professionals in Mexico who have a different attitude towards migrants and homeless population, because now they understand the context. So I think that's a critical aspect for for the future generation. Yes.
And I'll just add, as we have here, thank you for you and Tom for all of your championing of, everything Hfit. So, we're very indebted to you and to all the students that have participated to bring it up. Yeah. Yes.
This is actually a related question. I was curious, both sort of in these focus groups, I was really interested in that aspect of the different groups of students coming together and working together. So both if the UCSD students sort of talked about what they learned or their interactions with the students, the Mexican students, and similarly, if you were considering or planning on doing the similar related kinds of focus groups with that set of students or combined focus groups to see sort of what they're getting out of it and how the sort of learning processes relate and interrelate.
Sure. No, I think it's a phenomenal idea, and that's something that we could certainly do, in the near future. We haven't kind of gone in depth on that side. We really kind of wanted to learn more just about, the refugee side and the professional development. But that learning piece would be its own focus group. So I appreciate the suggestion. Yeah.
I have a question.
Yes.
So this program seems like it would be great for not just students who are interested in medicine or the health professions, but just in general. I mean, just in kind of growing social and civic consciousness among people in general. Do you have any plans to make this opportunity available or to kind of target other groups of students who might not necessarily be inclined to participate in a program like this to grow that?
Sure. No, we definitely do open it up to the UCSD community. And other students from elsewhere have volunteered. So we're not limited in our scope of participation. We had a very exciting group of students from bioengineering come maybe about 4 years ago. And that was very interesting. We did it as a pilot with that program and they brought their perspectives. But we always say, if any student is interested in this opportunity, please apply, because we think that there's so much room to participate, to innovate, and to kind of contribute your perspective, to this. And because there's very little bureaucracy, we have flexibility to really take it where students are interested in growing. So thank you.
We have one question that's come in from our remote participants. This is from Danielle Montejano of UCSF. Thanking you for this wonderful presentation. How does Hfit provide opportunities and resources for underrepresented students from a first-generation migrant refugee asylee background earlier in their academic career? For example, those looking to apply to graduate education. Does Hfit provide any mentorship to middle school or high school students?
We haven't gotten to middle school or high school, but we have, between Dr. Burgos, myself, and the faculty that we collaborate with and know at UCSD, for example, and other institutions, have supported students to do research projects that help them to build their curriculums. And sometimes they're funded and sometimes they're not funded, but we've supported a fair number of students in terms of applying for example, campus opportunities like the Trells Fellowship, McNair Scholars, and then of course, writing letters of support as they're applying for graduate admissions. We've had several students that join our groups as RAs, research assistants. So there are different opportunities and we try to steer them to those that have financial components as well as much as possible. But that is one area that we would love to grow, is to be able to have fellowships and to be able to offset, for example, even transportation costs to the border and things like that. So I think that's one area that we would love to grow in.
Great. Thank you, Vicki and Jose Luis. Our next speaker is Dr. Lillian Walkover, who is a critical global health scholar jointly appointed in the Department of Communication and in the Global Health Program here at UC San Diego. Her talk is entitled Pathways Toward Medical Licensure for Refugee and Asylum Asylee International Medical Graduates Living in the United States. So let's just make sure.
Okay. Thank you so much for that introduction. Today I'm presenting a paper written with Susan Bell. A longer version of this paper is currently under review. Thanks so much to the conference organizers for bringing together these important conversations and for including our work. Today I'm going to talk about healthcare providers who are also themselves refugees and asylees. So the American Association of Medical Colleges estimates that the US experienced a shortage of more than 20,000 physicians in 2017 and predicts that this will grow to a shortage of between 42,000 and 121,000 physicians by 2032. As we know, during the coronavirus pandemic, the need for physicians has become so acute that governors and health officials have called on retired physicians to return to work. Many states loosened licensing restrictions and waived licensing fees, and the Federation of State Medical Boards gave free access to its database to streamline the verification process. These efforts have targeted a range of physician populations, including both retired and student physicians, as well as international medical graduates, the population I'll be talking about today. So international medical graduates, or IMGs, makes up approximately 1/4 of all practicing physicians in the US, and thus are key resources in addressing shortages. IMGs tend to practice in underserved areas and to take care of more minority, Medicare, and Medicaid patients than US medical graduates. In addition, they have the potential to provide culturally and linguistically competent care for an increasingly diverse patient population. In US social science scholarship, IMGs are divided into US citizen IMGs, US IMGs, and non-US citizen IMGs, or non-US IMGs. For the purposes of US medical licensure, qualifications, and record keeping, US and non-US IMGs are lumped together. However, these categories are too blunt to demonstrate important differences among non-US IMGs. In the larger project of which today's talk is a part, we propose a new category of international medical graduates who are forced to leave their home countries, a group we refer to as refugee physicians. We use the term refugee physicians for 3 reasons. First, the term refugee physician focuses attention on how physicians are located among forcibly displaced people worldwide, including their distinct relationships to their home countries, countries in which some of them seek sanctuary before arriving in the US, and the US, where some of them requested asylum and others have been resettled. Second, because refugee is an umbrella term that blends categories of law, policy, social science, and everyday usage, it encompasses a wide variety of lived experiences along a continuum of compulsion to leave. Finally, refugee physician illuminates the group's distinct relationship to medical licensure and brings into focus structural barriers that impede their goal of attaining a US medical license. The piece we're sharing today focuses on a scoping review of nonprofit physician career assistance programs serving this population. In this presentation, I share the results of the review, including updates on how programs have been affected by the ongoing pandemic. So, to practice medicine in the US, all IMGs must obtain a US medical license. Their education must be certified by the Educational Commission on Foreign Medical Graduates, and they must pass the USMLE, the US Medical Licensing Exam, and complete a residency before applying for a license to practice. Here I want to note that recent changes in the USMLE, some of which were already under consideration, were catalyzed by the pandemic. These include the shift of the Step 1 exam to a pass-fail grade and the elimination of the Step 2 clinical skills exam, which is in turn related to the development of a set of pathways for ECFMG certification that combine different options for proving educational and clinical preparedness for beginning a medical residency in the US. So, this process of becoming a licensed physician in the US, including ECFMG certification and completion of a US medical residency, is the same for everyone who attends medical school outside of the US and Canada, no matter how much experience they may have had before arriving. Even again, if they've already, for example, completed a residency and practiced for 10 years in a variety of intense settings. Many non-US IMGs come to the US to pursue graduate medical education, but others enter the US for other reasons, after the completion of medical school and at different stages of their careers. In our study, more than 2/3 of the physician participants fled their home country because of violence, imprisonment, threats to safety caused by political or religious beliefs, or to avoid an unstable political climate. For these refugee physicians and other IMGs, gaining admission to a US residency is a key bottleneck in the process of gaining a US medical license. Of course, there are no formal regulations that require residency programs to favor US medical graduates, but graduates of US medical schools are more likely to be accepted in a residency. Even if non-US IMGs pass the required exams for entrance and become certified by the ECFMG, about half of them fail to match to a residency position each year. Key determinants include preparation for the USMLE, English proficiency, financial constraints, ability to study full-time for an extended period, specialty, and number of years since graduation from medical school. Matching requires strong social networks, notably US physicians who can write letters of recommendation, typically based on an applicant's performance in a US clinical setting. This pathway for IMGs to medical licensure in the US is time-intensive and costly and requires time, money, and social networks. So, during the past 20 years, a patchwork of programs has been established to support US medical licensure for non-US IMGs and US trained physicians who have left the workforce and want to re-enter medical practice. We identified 15 nonprofit programs that have helped over 5,000 physicians pursuing a variety of career options, including supporting at least 273 non-US IMGs gain admission to a medical residency program in the US. Each of these programs included in the review offer a combination of services, educational guidance, courses, and clinical experience. The review excludes for-profit companies because they're usually prohibitively expensive. So to develop this review, we first searched with the keyword physician reentry in Google, and with this keyword, we identified individual programs as well as 4 databases: the Federation of State Medical Boards, Directory of Physician Assessment and Remedial Education Programs, the Physician Reentry into the Workforce Project, the American Medical Association's Observership Program listings for international medical graduates, and the Imprint Program Map. Website review and email outreach to the identified programs and databases yielded a list of 16 programs that offer services available to non-US IMGs seeking US medical licensure. One of the IMG-specific programs, the Welcome Back Initiative, is an umbrella organization with at least 8 Welcome Back centers that serve physicians at the time of the original search. While the initial analysis for this paper was conducted in 2018, in 2021, we reviewed each of the listed programs to see how they have been impacted by the ongoing COVID-19 pandemic and updated the list. Overall, non-clinical, as you'd expect, educational and mentorship services have been moved to remote services, remote formats, and 2 Welcome Back centers no longer qualified for inclusion. One shifted away from serving physicians and another closed. One new organization was in the process of being founded during the initial study period and has been added to the list. This brings the current total to 15 programs. In addition to reviewing the range and status of programs, we also checked for updated numbers reflecting the impact of each program's work. However, no updated statistics on the number of physicians served were available, presumably because of the pandemic. So, all of the programs are nonprofit and all provide some type of support towards certification by the Educational Commission on Foreign Medical Graduates and admission to a medical residency. Many of the programs provide services to IMGs in a geographical area within one state, while others have chapters across the US. The review shows that in many areas of the US, direct services for this population are not available. The organization with the broadest geographic reach is the Welcome Back Initiative, an umbrella organization founded in 2001 by Jose Ramon Fernandez Peña, an immigrant physician who faced barriers to practicing in the US and is currently the president of the American Public Health Association. The Welcome Back Initiative runs Welcome Back centers in partnership with local organizations. Each Welcome Back center works with a community college or regional health center where educational case managers provide assessment, guidance, and access to education for immigrants from a variety of health professions. WBCs have served approximately 15,000 internationally trained health workers from 167 countries. 1/3 of these internationally trained health workers are physicians, and 128 physicians served by Welcome Back Centers have been accepted into residency programs. At the time of the updated review, we identified 5 Welcome Back Centers that provide services to physicians. So there are 2 programs in California and Minnesota that provide support for clinical training, which, as we've discussed, is a crucial step to US licensure. One is hosted nearby at UCLA and enrolls IMGs willing to commit to a family medicine residency program in California that serves an under-resourced community. To qualify, students must have finished medical school or residency in another country within the last 5 years and be bilingual and biculturally competent in US American and Latin American cultures. The program supports participants during the process of testing, certification, and application to these residency programs. The Minnesota program, which has the same name, but is distinct, was founded by a physician from Liberia who faced barriers to US medical licensure and seeks to relieve the primary healthcare shortage in Minnesota. It provides career guidance, financial support, and residency preparation. As of 2018, the program had a database of 150 non-US IMGs. 130 of these physicians were actively pursuing a residency, and 20 had been accepted into a residency program. In addition to these sort of larger programs, 3 smaller scale programs focus on educational case management and connect non-US IMGs to language and other courses. The White Tulip Health Foundation is an association of health professionals with 24 different chapters that provide mentoring, career guidance, and workshops on healthcare topics. GT Docs, or Global Talent Doctors, which is part of a regional initiative in Idaho and Utah to support immigrants, provides customized plans for individual medical professionals and peer support for US MLE preparation. The Washington Academy for International Medical Graduates was developed by a group of IMGs in Washington State who had been engaged in policy advocacy and provides a range of mentorship and career guidance. The Academy is also working on providing links to research and clinical experience. Zooming out a little bit, there are 3 other programs in the review that target a broad population interested in re-entry to clinical work and provide resources that are also useful to non-US IMGs living in the US, such as clinical experience and online education and self-study resources. The Drexel Medicine Physician Refresher and Re-Entry Program provides online clinical skills courses and clinical preceptorships for US educated physicians returning to clinical work and IMGs. CPEP's Return to Clinical Practice Program and Texas A&M's K-STAR Physician Resources provide programs that are open to non-US IMGs, but do not target this population. One sort of additional keynote on these kind of programs, observerships have the potential to improve an IMG's chances of getting into a US residency program by providing opportunities to observe medical practice in a US clinical setting, connect with a social network of insiders, and identify physician mentors to write those crucial letters of recommendation. According to American Medical Association guidelines, the completion of an observership should not be considered a required step on the path to a residency program. However, 90% of non-US IMGs complete some type of US-based clinical experience before successfully matching to a residency. So it's basically an implied requirement that's not stated. The review identified 7 programs that provide access to experience in US medical settings, including links to observership programs, residency preparation programs, clinical rotations, preceptorships, and other forms of supervised clinical experience. However, many observerships are expensive and run by for-profit companies and can cost as much as $5,000 per month. Here's an example of one for-profit company that has received over $1 million in venture capital funding. So the small number of programs identified by this review have had modest but important successes in providing career assistance services to more than 270 non-US IMGs that have matched to residency programs. But they are out of reach for many refugee physicians and other non-US IMGs living in the US. As a whole, the nonprofit career assistance programs identified by the review are providing educational guidance, English courses focused on technical language skills, access to observerships or other forms of clinical experience, and crucially, financial support for the cost of certification, licensing exams, and application to residency, all of which can add up very quickly. However, no one program provides all of these services. So additional research is needed to assess the effectiveness of these programs and to prioritize the importance of the different services they offer. A large-scale study of the effectiveness rates of the 15 programs, including follow-up with non-US IMGs who achieve US medical licenses, would help to inform expansion of these types of services to the many states where no support is currently available. Of course, qualitative research can shed light on the experiences of individual physicians on the pathway and service providers assisting them. In our current study, based on in-depth interviews with service providers and refugee physicians, we are identifying what led some non-US IMGs to successfully match in residency programs and others to be unsuccessful. The first paper from the larger study, The Case for Refugee Physicians, Forced Migration of International Medical Graduates in the 21st Century, was published this spring. However, only some of the physicians in the larger study were supported by one of the 15 programs described today. So these programs are emerging, and their evolution will be important to understand in light of efforts in medicine to increase the number of physicians in the US and to foster the development of diverse, culturally competent physicians in a changing and mobile global environment. This review represents an important step in that direction. In addition, each of these dynamics have been impacted by the intersecting forces of the pandemic and the urgent need for clinical care, as well as ongoing forced migration around the world. In the larger project, we make visible the potential contributions of refugee physicians to the country in which they now live. When these physicians can gain US medical licenses and practice the skills they have worked hard to learn in a career that they love, the US gains needed physicians who have strong clinical expertise. In addition, these physicians bring linguistic and cultural competencies in which the US healthcare system is clearly deficient, often paired with experience and willingness to work in under-resourced settings. As we face unprecedented burdens on our healthcare system, it has become increasingly urgent to make visible both the category of refugee physicians and the contributions they stand to make when they are able to practice medicine, and to provide pathways and resources to help make this possible. In closing, we are grateful to the organizations that work in this field, helped us recruit refugee physicians for the larger study, and participated in interviews about providing support for IMGs. Thanks as well to our undergraduate research assistants at Drexel University. I look forward to your questions.
Thank you, Lillian. Questions from the audience in the room first?
I have a question. Yeah. So looking at the list of organizations that were creating programs, they seem to be university-based, maybe tied to medical schools. I'm interested in the role potentially of other kind of American professional organizations. Were there any structural barriers to, opening up new pathways to licensure? Like, do they feel a threat? Were there other sort of structural forces sort of mitigating against expansion that you found, or do you anticipate that that's potentially a problem?
Yeah, so the only one of these connected to a medical school is the UCLA program. Everything else, it's very strongly sort of coming out of community-based organizations. The support that is there is strongly coming out of community-based organizations and sort of refugee and immigrant serving organizations, as well as organizations of immigrants and refugees from particular communities. But yes, I mean, has been a very strong history of US protectionism of US medical graduates, which is part of why we have the shortage in the first place, right? So part of all these dynamics is it the 1996 or 1997 cap on funding for residency programs, which was partly put in place, with support by the American Medical Association, sort of to stem the tide of international medical graduates coming into the United States. And it's a case of sort of the American doctors did too good a job of protecting their position, and now there's not enough doctors in the United States. And yet we're still drawing on these populations from around the world. So there is this really interesting, and now, American physician organizations are starting to support sort of reopening or some kind of expansion of funding, sort of going back against the initial sort of stops that they put in place. So yes, there's a lot of protectionism. And then there's also sort of a bifurcated, even when you do get into residency programs, a great book came out last year or the year before. The pandemic sort of messes up time, but sometime recently, Tanya Jenkins, about sort of the different kind of residency programs that people are tracked into and the different kinds of education that you get in residency programs that are primarily recruiting US medical graduates versus international medical graduates. Yeah.
Hi, this was really interesting. My question is whether this problem exists in Europe and other countries, for instance, in England and in Germany,
yes,
and everywhere else. So were you able to have a global view of what other countries are doing specific? Because as with doctors and lawyers, your particular qualification matters and is certified by the country. Yeah. But even if you move from one country to the other, you may have language, etc. So of course compounded for refugee populations. Yeah. But what happens elsewhere?
Yeah, so I think like many things between the US and Europe, it looks so much better in Europe. And then of course, once you're actually in Europe, there's still a lot of bifurcation and issues. And so, for some participants in our study, their relatives were more able to practice medicine or more quickly able to practice medicine in other countries than in the US. That doesn't mean they didn't face significant barriers. So there's similar sort of structures of having to relicense, but I'm trying to remember, certainly Germany and the UK, but I mean, most countries have put in place sort of different levels of these question of sort of how do you assess somebody's education, their licensure, and make sure they have some amount of clinical experience in the country in which you're then granting them a license. I'm forgetting the exact process in the UK, but it is both significant and easier than the US process. You don't have to fully repeat your residency, basically, because again, sort of in the US, the deal is doesn't matter how long you practice, you're basically competing with fourth year US medical students to get into a residency. And that's the position. You're sort of knocked back to the fourth year of medical school, but you're actually sort of ranked below a bunch of those students. And so most other countries have at least some structure that allows people to sort of take exams or otherwise sort of be evaluated to figure out where they actually are in relation to being ready to practice medicine in that country. And then in some countries will actually accept medical licenses. So for example, like an Iraqi physician can practice in Jordan, but won't be eligible for citizenship in Jordan because of the politics of, sort of the international refugee regime. So yeah, no, it's a great question. And the short answer is everybody else does it better than we do, but there's still huge barriers in other countries. So for example, that woman, one of her siblings, she's still not a physician in the US, is very frustrated by that. And she has a sibling, I believe, who is a practicing physician in the UK and another one who's a practicing physician in Jordan. So they did face barriers, but were able to achieve those goals in a way that she has not.
Thank you.
Yeah.
Well, I was curious if you see that these foreign medical graduates are going through a lot of debt to try to kind of achieve that goal here in the US, and then how that plays out.
Yeah, absolutely. I mean, a lot of them aren't in a position, I think, to sort of borrow like structurally. So they're mostly borrowing from family. And I would say the people who are even able to pursue this at all are able to pursue it because their parents are effectively giving them or lending them $10,000 to $20,000. And it's because their family has that as a gift, effectively. They're mostly they're not taking out loans that we saw. Mostly they're only able to even try because there's some significant, amount of sort of family financial flexibility that they're able to draw on. No, those aren't true. Some of them do max out credit cards and take out. The processing is incredibly expensive, as anyone who's ever applied for residency. I mean, even just these exams are thousands of dollars to take. And then, of course, as many of you guys know, we're physicians to go through this process of interviewing. You have to pay for flights and meals and hotels, and the whole process is based on an idea that you are a upper middle class fourth year medical student who is basically not paying any of your own expenses. and has no responsibility, right? No sort of childcare. Most of the physicians, I think all the physicians who matched were in our study were men from the Middle East, and most of the physicians who had applied but had not matched were women. And you can see, the impact of caregiving on, time to study. And people were taking care of their children and doing a job and applying to medical residency, but because of the sort of extra time that puts in, the impact on your scores, if you can't study for as many hours, you can see in the end that their rate of matching is lower. Yeah.
Hi, first, thank you so much for the work that you're doing. I'm an IMG myself and a daughter of refugees from Jordan. So I worked with refugee physicians in Jordan, and I know how much of an asset they are to the country.
Absolutely.
So this work can really be transformative to the way we do healthcare in this country here in the United States. My question to you, have you thought of taking this to the policy level, to the next level, and interviewing those who could act like roadblocks, such as people at the AMA, the American Medical Association? Could that be the next step for your research?
Yeah, absolutely. So one caveat is that this was my postdoc project, so it's really Susan Bell's, conception and sort of her choice what happens with it, and is continuing to do great stuff with it. We still have a lot, honestly, even from this that, we just published the paper looking at the physicians, but we haven't even published anything about the service providers we did talk to. But yes, I do think that would be incredibly valuable. I think interviewing, personally, one study I would really like to do, and people have done informal versions of this, but interview the residency directors, the residency program directors, because they're responding to all these forces impacting on them, but they're really these incredible gatekeepers in this process. Obviously, the federal funding and I don't know why I can't remember if it's 96 or 97, funding cap on reimbursement, basically, for residency positions is a huge issue. But yeah, I think that interviewing them is really key. And honestly, a lot of, we think of these systems like the match, if you go to the US Medical Residency Match website, they're like 2 Nobel Prizes have been won for this algorithm, which makes you think that it's this impersonal algorithm. But so many of the people who did match in these cases, it's because somebody knew somebody who talked to the program director and said, I know you would otherwise throw out this file, but look at it. And the most horrific one, and I won't tell you who this happened to for their anonymity, but I mean, we did have somebody who basically was admitted to a program, and they basically told her, like, if you donate the cost of your medical residency to us, which is always estimated at about $200,000 to train a medical resident. So if you, statutory refugee, will just donate $200,000 to our institution, we'll let you in. So, we pretend that these things are this medicine is above all of these things, but medicine is full of humans who make human decisions, including correct ones. And so, yeah, absolutely. I think the residency program directors would be a really interesting group to intervene on and to sort of interview, but certainly the policymakers. And there are efforts. I mean, Jose Fernandez Peña, is a huge figure in this field. Obviously, he's now running the APHA. Has helped submit multiple pieces of legislation, and there are ongoing efforts at high levels, at state levels, and at national levels to change some of these pieces. So yeah, I think there are very clear policy implications. This was a qualitative sociological study, so it wasn't meant to inform policy, but certainly, hopefully, to inform people who are informing policy. So absolutely. Thank you for bringing that up.
Great. Thank you very much, Lillian.
Wonderful. Thank you guys so much.
So our next paper is by our own group here at UC San Diego Global Health Institute. I'm one of the authors, Tom Csordas. I'm a professor of anthropology here at UC San Diego and director of the Global Health Program in the Global Health Institute. My co-authors are Brenda Wilson, who is a postdoctoral scholar in the Global Health Institute and a lecturer in the Global Health Program, and Alexis Burnstan, who is the program coordinator for Global Health Institute and for the Tracing Asylum Seekers Trajectories Project. And our title is An Ethnography of Care, Physicians and Asylum Seekers on the US-Mexico Border. This, what you see in front of you now, is the team, the research team for tracing asylum seekers' experience and trajectory, which we have funding from the UC San Diego Academic Senate and the binational Proyecto de Investigación en Migración y Salud. Brenda and I will be sharing this presentation, and so I'll take the first 10 minutes and she'll take the second 10 minutes. Our project began at the end of 2018 with the wave of caravan that were coming to the southern border at the time. And we were provoked into starting our research by that series of events. And to be precise, we were provoked into it in large part by the image that you see in front of us, which we found to be incredibly disturbing and provocative. And we began from that point to engage in what we call an ethnography of care, with the goals of which are to document the evolving networks of healthcare for refugees and asylum seekers, and to describe the lived experience of both healthcare providers and asylum seekers. Since March of 2020, we've also been concerned with how this situation has been exacerbated by the coronavirus pandemic. We're going to focus primarily on the part of our work that we've done with the healthcare providers, because they need to be paid attention to, and not only the experience of the asylum seekers. Our study so far has interviewed 43 people in the US-Mexico border area who work for a variety of healthcare provision and service provision organizations and agencies that you see listed here in front of you. One of the biggest issues that we have faced right from the beginning in looking at people volunteering in the face of the crisis of refugee and then the crisis within the crisis, the coronavirus pandemic, is the challenge of preparedness for healthcare providers in a humanitarian setting. And the fact that regardless of how well-trained one is, it's not always the case that a person is or can be completely prepared for what encounters. We're going to draw first from the master's thesis of Tiana McMahon, one of our research team members, which focuses on the distinction between institutional and clinical preparedness. The challenges of institutional preparedness begin with unpredictable increases and decreases in the number of refugees, as well as changes in immigration policies, difficulty in securing adequate staffing, barriers to care in the medical bureaucracy, and lack of adequate communication and communicative channels. The challenges of clinical preparedness include unfamiliarity with rare infectious diseases, complications from pre-existing conditions, mental health effects of trauma and torture of multiple kinds that may be layered one upon the other, sexual and reproductive health of women who flee while pregnant, language barriers when asylum seekers may be arriving from multiple countries, and on the other hand, over-specialization of clinical volunteers. These two quotes that you see on the slide are, you can barely read those. Maybe we need to put the shades down back there. Is it, you can see them okay? Okay, so one of the physicians was saying, the previous 15 years I've been working primarily as a clinical and metabolic doc, which puts you in a very specialized place. I did primary care for my patients that had rare diseases, and I was briefly comfortable seeing both kids and adults in that context, but had not really worked as a straight pediatrician for a number of years. It was anxiety provoking at the beginning, whether or not I would be able to make it work, whether I still have the skills and ability to do it. And another said, what am I underprepared for? A lot of times stuff comes up, which is like what you think of as a simple question or routine problem, but because I'm not boarded in family practice, I wouldn't know the answer. Every time I go to the shelter, I have to look again at certain protocols because I would be completely lost without the protocol, even if it is something really simple, Like, what's the antibiotic for otitis media? Like, I don't know that. I'm not a family practice. I don't treat otitis. I have to look it up every time. You know, simple stuff like that that I would be underprepared for. My point here is quite simply paying attention to the experience, the frustrations, the lived experience of our healthcare providers is an important element of what we have to understand in dealing with refugee and asylum seeker health and well-being. These were interviews that were done really before the pandemic struck. Once the pandemic struck, things, of course, got even more complex. And we found that this is the case dealing with migrant clinics at the port of entry and in detention centers. Now, I'm going to say just a couple of things about the first two, about migrant clinics and at the port of entry. One of the places that we have worked most closely with is our own UC San Diego healthcare clinic for screening asylum seekers and refugees at the Jewish Family Services Migrant Family Shelter. And one of the first things that we got in our interviews from the first year of the pandemic was the coming into the clinic of people who were from China. And the doctor who we interviewed is saying, and laughing incredulously, yes, that was total racism. They were Chinese. They had not been in Wuhan. They hadn't even been in China for over a month. But Border Patrol sent them in N95 masks and scrubs and all their belongings in a garbage bag. It kind of just raised red flags, but then we spoke to them. They had already been screened for COVID and quarantined. They were totally asymptomatic, so we just realized that, laughing again and rolling her eyes, this was just purely because they had Chinese passports, but they had actually spent like over a month in Mexico before they were detained. And then they were quarantined for 14 days, so they were like, definitely didn't have COVID. And it was when we had just a few cases here in San Diego and everyone was just getting very anxious. So here you have the immediacy of the lived experience of the healthcare provider confronted with an instance of explicit racism in dealing with a group of Chinese immigrants who couldn't possibly have had coronavirus. From the same clinic, a year later, we have a comment like this from a physician. Like everybody across the world, we've all been affected by the concern of infection and the steps we've had to take to keep ourselves from getting infected. So, you know, massive social disruption to our lives with creating pods or worse, isolation, being separated from family members. I just saw my sister for the first time in 2 years. If we've been fortunate enough to not get COVID and not have either long hauler syndrome or death, then we've had to consider how to take care of ourselves in this new world. Professionally, my group and my colleagues had a massive disruption in the way our lives went. It's just massively increased the workload in addition to our regular jobs and that workload. Our research was disrupted. I think everybody's been worked very hard, no question. I mean, I probably work 60 to 80 hours a week. Moving to another setting, physicians who are actually encountering refugees and asylum seekers for the first time as they come across into the port of entry. In the first year of the pandemic, we had the physicians saying, as a physician in leadership, when you're interacting with Customs and Border Protection, you do have to maintain some form of relationship with them or everything's lost. And again, we have a laugh. Those telling chuckles are very telling. And as a physician and a human being, you don't want to turn a blind eye to what your colleagues or advocacy groups, to any of the big tent of ideas and say, no, we can't do that. I get the sense that the Border Patrol loves Title 42, the legal authority they're operating under currently because of the public health emergency. It makes their job that much easier. People get tossed back to Mexico quickly. We don't have all these pesky pregnant women and kids seeking asylum. You know, that's kind of the cynical way I said it. But my observation is that Title 42 is the dream of this, the Trump administration, when it comes to immigration for asylum seekers and similar groups of people. And again, you have that coming right in the first wave of the pandemic when physicians are trying to deal with and cope with relations with government officials in the immigration sector. A year later, we have a comment from the same group, physicians saying, the thing I see most commonly is the minor injury, but still maybe a significant enough injury that would require an operation or something else. And they'll say, we're not going to do it. We're not taking them. They're going back to Mexico. You know, they're on the list to go back this evening or whatever. So we saw that early on, and they're probably still doing it. The same with COVID. We'd identify an individual we were concerned about having COVID. You know, the answer would be, no, we're not taking them to the hospital to get tested. We'll Title 42 him and send him back to Mexico. So we would have someone sick, potentially with COVID, being sent back to Mexico to go to the doctor there. I mean, knowing full well that most of these folks really don't have access to help. In general, there is still no COVID testing at these frontline facilities, whether it's a port of entry or a border patrol station. So here we have examples from two places here on the border dealing with asylum seekers. Two different places in 2 different years of the pandemic. They are describing concrete situations that they're dealing with, but I ask you to look behind those concrete situations and see the implicit frustration, the implicit stress, the implicit emotional consequences that these situations have for the physicians themselves. And these are physicians who are deeply committed, and physicians who sometimes are more than committed, who actually lay their bodies on the lines for the sake of refugees. This photograph of a physician protest was taken in December 2019, just before the onset of the pandemic. And it was a protest at the conditions for asylees who were in detention centers. And this is in the wake of a flu outbreak that was going through detention centers. So again, point is, let's pay attention to our healthcare providers along with the experience of the asylum seekers. And this is a theme that Brenda will take farther. And I think that Dr. Murphy will take even farther when we have her presentation.
Thank you. Welcome, everybody. It's lovely to see everyone here. And so now, as Tom said, I'm going to kind of turn our shift a little bit more to look at what other various states along the border with between US and Mexico are faring in relation to providing care for asylum seekers during what we're calling this crisis within a crisis. So one way that we are doing this is by participating as a member of the US-Mexico Border Alliance Group, which has been spearheaded by Save the Children, which is an international NGO. So the Border Alliance Group was really initiated in November 2020, essentially in the lead up to the US presidential election and in the lead up to potential shifts in policies. And so at that time, there were many border communities who were already convening to strategize for all different potential outcomes following the election. But there was a need for a centralized group to really drive resources. And this was something being highlighted by all of these different various border communities. And so the Border Alliance then was created to fill that gap. And Save the Children then essentially became this umbrella organization to help facilitate all of this. So in addition to our tacit team, So in addition to our tacit team from UCSD, there are a vast number of other participating members and organizations that are part of this Border Alliance Group. And so this list is not an exhaustive list, but it does give you a general idea of the breadth of expertise that is sitting on these calls. They are once a month calls. And again, representing organizations internationally and domestically, and representing all of the 4 border states between California to Texas. And so these range, for example, from federal and state and local government agencies to cities and county officials, numbers of universities aside from UCSD. There's a number of international and US-based humanitarian organizations like the American Red Cross and others. as well as many volunteer groups that are sort of on the ground at the border, bringing basic necessities to the asylum seekers that are waiting, especially on the Mexican side of the border. And there is even the participation of a corporate entity. Greyhound Bus Lines was recently added on to these Border Alliance calls, especially for their role in transporting asylum seekers from the shelters to their destinations where their sponsors live. So, and what we are seeing and hearing from these monthly Border Alliance calls is how each state, and even within states, various regions are at times dealing with varied and diverse different kinds of challenges in relation to meeting the care needs of asylum seekers. And so we are going to present 3 different kind of emergent themes that really reflect this kind of state of flux, which is feeling the uncertainty, not only amongst care providers, but also asylum seekers themselves, in ways that ultimately affect well-being. And so these 3 themes that we will be discussing today are this sort of like this idea of policy environment always in flux, looking at the migrant protection protocols in Title 42 in particular. The second theme is then COVID testing and vaccination, always in flux. And that has somewhat to do with many factors, but one of those is the role of the state in relation to funding. And then the third and final theme would be nationalities of asylum seekers at entry, and then the communication phenomenon. So the first theme then is this idea about the policy environment always seemingly being in flux. And so Title 42, for example, and many of you will be familiar with this, but for those who are not, Title 42 was essentially invoked by the Trump administration under the claim that migrants might be bringing in COVID-19. And so this Title 42 was invoked, and it dramatically restricted immigration, ultimately blocking asylum seekers from their legal right to apply for asylum at ports of entry. The Biden administration has so far kept this in place, despite the pleas by immigration advocacies to lift it, and despite the fact that we now have widespread availabilities of COVID testing and vaccination. Title 42 has, up till the latest figures, prevented around 600,000 people from seeking asylum in the United States. Just since September the 19th alone, looking at the Haitian population, approximately 7,400 Haitian refugees were expelled under Title 42. Essentially, this is problematic for a number of reasons, but these expulsions are occurring at breakneck speeds, suggesting misuse and abuse of Title 42. And then the second policy, the migrant protection protocols, this was also invoked under the Trump administration and enacted in January of 2019. And this required asylum seekers to wait in Mexico for the entirety of their legal cases, which can take several years. During this policy, approximately 60,000 were sent back to Mexico to wait between January and October of 2019. And this resulted in these kinds of makeshift tent encampments alongside the Mexican border, where asylum seekers were made to wait. And then after Biden took office, the MPP was ended, but then there are rumors about it partially being reinstated again, and now it's being held up in courts. And so all of this kind of policy environment is creating confusion. It's creating a lot of frustration amongst asylum seekers and their care providers as well. So based on care provider interviews, we know that asylum seekers have strong medical and health needs. Without clear information about how what's going to happen with the MPP and for how much longer Title 42 will be in place, this uncertainty may increase asylum seekers' desperation and their suffering. So, for example, the Hope Border Institute has found that Title 42 expulsions are creating confusion and, in fact, driving more dangerous crossings across the Rio Grande and other dangerous crossings across the border. And then the threat of possible reinstatement of MPP, along with the prolonged Title 42 expulsions, has frustrated families in shelters in Mexico, increasing a sense of overall helplessness. And that was a quote out of the Save the Children at the Border Alliance calls. and another, sort of like aspect of this is that although our interviews with care providers are certainly important to understanding the different kinds of challenges that asylum seekers are facing, it's really important for us to listen firsthand to the lived experiences of asylum seekers themselves to really fully understand the magnitude of how these policies, always in flux, are impacting their health and well-being. And so the second theme then is about COVID testing and vaccination of asylum seekers is always sort of manifesting in various different states in terms of availability. Shelter by shelter seems to be very different. Recent developments have seen some states faring better than others, and this can be seen especially when we're looking at California compared to Texas. So California has been able to grow in capacity, especially with the state's recent commitment to $28 million. The state of California is in sharp contrast in comparison to some of the other border states that have emerged essentially against Biden's immigration policies. Texas, in comparison, does not have that same level of commitment at the state level for asylum seeker care. So in March 2021, Greg Abbott turned down federal assistance from the Biden administration for COVID testing while simultaneously blaming immigrants for bringing in COVID infections. And this, of course, leaves cities and individual shelters to their own means to find ways for funding testing. And then the third and final theme is this sort of overall uncertainty about the numbers of people that are coming in at any given time, the nationalities, the flows. So at present, mostly Title 42 exempt nationalities are being received across states and shelters. These include populations of Venezuelans, Cubans, Brazilians, Haitians, and others. The immigration agencies like CBP are giving little to no advance notice to many of these shelters about what time or how many or the numbers of asylum seekers that are coming in. And this kind of further burdens this volunteer shortage of being able to really, provide the kind of care needed at any given particular time. And so this kind of phenomenon is really captured by one of the quotes from a clinician based in San Diego, who said that with the semi-reinstatement of the MPP and ongoing use of Title 42 to essentially return anyone, we'll have waves and we never really know who will receive it at any particular moment. At one point, pregnant women from Haiti were coming in, but now we're not sure. I don't know why that is beyond this bigger notion that there is this fairly predictable variability in who happens to be here at any given time on policy. And so I think that really captures this idea of the frustrations about all of these changes in flux that are taking place.
Brenda, can you explain the Title 42 nationality exemptions? Who's exempted and why?
Yeah, and so there's a lot of confusion around that as well. And so essentially, Title 42 has been legally, if it's being applied as it's supposed to be directed at Mexicans and Central Americans being returned back into Mexico. But what we're hearing on these border alliance calls is that that's not necessarily being enacted, and all kinds of people are being sent back to Mexico that are not supposed to be. Haitians, for example, there are flights of Haitians returning back to Haiti, but this is kind of like feeling this whole overall idea of this general uncertainty about what's going on. So yes. So and even people on the border alliance calls are very baffled by this, like exactly what's going on and how this policy is being enacted. And so it's just a couple of concluding remarks. So although networks of care have demonstrated remarkable resiliency amidst a state of uncertainty, it certainly poses difficulties for care providers nonetheless in order to fully meet the needs of asylum seekers. This constant flux of policies creates this sort of overall sense of uncertainty, increasing the desperation and decreasing overall well-being of asylum seekers. And so these kinds of fractured and disjointed efforts across the state are really an indicator of failures at the federal level. So our flawed asylum system and the lack of political will to fulfill its international mandates and own domestic laws is certainly something that needs to be taken more seriously. On that note, the U.S. asylum system is can be thought about as a racialized structure of violence. And so anytime that these politicians like Greg Abbott, or even like the wider public that is perpetuating this myth of the disease-ridden immigrant, are essentially perpetuating a more than 100-year-old racialized trope that continues to inform immigration policy, which bears on the need for us to move past this for a historically informed approach to understanding disease and immigration that does not resort to racialized stereotypes and scapegoating of immigrants. And ultimately, whenever we're thinking about policies, it becomes essentially very important to think about the effects of these policies and the violent spaces that they are creating. One of those violent spaces was certainly those refugee tent encampments that came out of the Trump migrant protection protocol. And so that these tent encampments not only made more vulnerable asylum seekers to COVID infection in these tent encampments, but also to gang violence. So kidnappings and beatings became very commonplace. These are just images of the camp along the Matamoros, Mexico. And so in thinking about these creations of violent spaces, I'm reminded of Mbembe's concept of necropolitics, which he has described as these forms of social existence in which vast populations are subjected to conditions of life that confer upon them the status of living dead. And so on that note, I would just reiterate what Tom was saying at the end of his talk, that we need to have sustained advocacy by care providers for promoting healthy policies. Thank you.
We have a few minutes for questions, if there are any, before our break.
I have a question, and because I've been curious about what happened with the Haitians in Del Rio. So like with the MPP, we had, like a couple years worth of time to basically organize groups outside of the government in order to provide medical care or relief to the people living in those encampments on the other side of the border. But when we had that group of Haitians come, and then the US was so swift in getting rid of them, it wasn't clear to me that anything had been organized apart from the governmental effort, which I will speak briefly to, that was organized by the CMO of DHS. Do you happen to know if there was anything that was happening with other groups? And then also, the thing that I heard that I haven't been able to corroborate is that those people were mostly Haitians, but that there were a number of other Black migrants in that group. And I heard that they had all been deported to Haiti, regardless of their nationalities. But I don't know if you know more.
Yeah, so there are Haitians, just to answer the first part of the question, there are Haitians at other ports of entry other than that Del Rio, but Del Rio certainly has seen like the largest numbers of Haitians. And, to the second part, there on the Border Alliance calls, particularly with the El Paso sector and other Texas groups, there's this sort of noticeable anti-Blackness enactment of the policies. And this is very problematic. And as you said, there is some conflating of Haitians with Cameroonians and other African populations. But it kind of ties back to my comment or answer with Seth, is that this Title 42 is being used to invoke whoever, whatever, whenever, to whatever countries, regardless of how it's supposed to be, actually enacted. And all of this is just, it's very frustrating for asylum seekers, to say the very, very least. Nobody knows. In fact, even the transportation, some of the calls, the shelters will talk about how Haitians, but also other populations as well, are being put onto some of these buses and then trotted off to another city without even knowing where they're going. And then once they're at that destination, then they might sit in holding for a while and then ultimately be flown, and still not knowing where they're going. And so, this is like sort of this theme, right, that's coming out about like these things are always in flux. It's always, it's creates a bunch of fear, it creates a bunch of confusion, and just ultimately just impacts everybody's, overall well-being. Yes.
We have one question that's coming in from one of our other participants, and then we're gonna actually have to go to break. This is from Kristen Yaris from the University of Oregon. And she's saying it's interesting to consider physicians as political actors in the US. In other countries, doctors and health professionals are often on the front lines contesting political and economic policies, but we see this type of overt political action less often in the US. Perhaps a reflection of structural differences, like a lack of national healthcare system in the US and privatization of US medicine. At the same time, US physicians have a lot of moral authority culturally, suggesting that if they are to take a lead as political actors, that would have a large impact socially. Just wondering your thoughts on health professionals as political actors demanding policy changes. We all think of physicians as very overworked, and becoming political actors and activists is an additional demand. This is why we're bringing attention and admiration to those physicians who do take on that additional role. And I won't say anything beyond that, because I think this is an issue that's going to be directly addressed by our next presenter right after the break. Is Dr. Donna Murphy, who is a neurologist, neuroscientist, historian of science, and community organizer. She is co-founder of the patient-centered, justice and equity-oriented political action committee, Doctors in Politics. Her title is Global Health is also investing in political change of the systems that drive the harms we are made to chase. Dr. Murphy.
Thank you very much. So I'd like us to consider this title as we think about some of the issues that I will present. So many of you may be familiar with this quote by Audre Lorde. This is a statement that demands that we examine whether it is possible to in fact dismantle systems of oppression by the artifacts of those systems. When we're thinking about the global refugee crisis, we should think about what those artifacts are. This quote captures a theme that will present itself repeatedly throughout this talk, and it demands iterative reflection. Over 80 million people are fleeing persecution, conflict, violence, and human rights violations, or are internally displaced within their own countries. What mitigates harm within and beyond these countries has to do with government policies, whether they are just, equitable, sustainable, and accountable. These governments are the governments from which these people flee, as well as those in which they seek refuge. Where governments are perpetrators of the harms indirectly or directly, the work of NGOs also becomes important. Here we should also problematize the ostensible success of NGOs as the vehicle by which we perpetuate broken governments. Consider how the nonprofit industrial complex muffles the pressure for transformational change of systems. Growing our consciousness of the challenges to the health and well-being of refugees, asylum seekers, and forcibly displaced people requires that we show up with them in the face of injustice that they flee and the injustice that they fight. My experience as an immigrants' rights activist and eventually as an immigrants' rights organizer helped me to appreciate that governments can be ruthless to those who are already most vulnerable. In 2017, so this is something taken from 2017, the Texas State Legislature passed SB 4, which is an anti-sanctuary law that racially profiles Black and Brown people, separates families through the immigration, detention, and deportation industrial complex, and undermines health and public safety with decreased utilization of health and social services and decreased reporting of wage theft and violent crime by communities who are fearful of facing deportation in their engagement with law enforcement, the judicial system, as well as government agencies. In this op-ed that I wrote here to the left, in 2017, I brought attention to the fact that there is a powerful historic correlation between anti-immigrant legislation and decreased health service utilization that should give us all pause. Congress passed the Personal Responsibility and Work Opportunity Reconciliation Act in 1996, which restricted access to publicly funded healthcare services to undocumented immigrants. Explicitly, this was to remove incentive for illegal immigration. Not only has this decreased utilization among our undocumented communities, but there has also been a reduction in Medicaid participation by eligible immigrants, including the US-born children of undocumented parents who already experience multiple intersecting systems of disadvantage. These same outcomes have been seen with anti-sanctuary laws like SB 4 in Texas, 287G agreements between county law enforcement and ICE, and the parade of anti-immigrant policies that we saw coming out most recently from the Trump administration. The second picture was of the launch event of Project Lifeline, which is a nonprofit I started in 2018. This nakedly cruel Trump administration policy of family separation created a moment to educate Americans more generally about the industry of child detention, the deprivation, the dehumanization, the toxic stress, and enduring trauma. This was in place actually for some time before the Trump administration, but he magnified the harm with over 5,000 children separated from their biological parents, hundreds of whom have not been reunited even 3 years later. This video is of a viral action, which I'll play in a second, that I helped facilitate for a good friend when Trump decided to rescind DACA based on legal pressure generated by the Texas Attorney General, Ken Paxton. A second. Oh, how do I play this again?
Well,
my question is, why are you trying to deport me?
I'm actually just trying to make sure that the President of the United States follows and they take accomplishment.
Why are you trying to separate families like mine?
I'm asking the President of the United States to follow the law.
Why are you trying to criminalize over 100,000 young people that's in prison? DACA has provided physical and security.
I'm not saying it's
stability for me and my immigrant brothers and sisters.
It's unconstitutional. When the president and you can't do that. You can't make up law. That's what he did.
DACA has provided for me, has opened doors for me to provide for myself and my family.
I'm not saying it's not what I'm saying is you understand that we have a constitution. If we don't follow the constitution, we lose the whole thing.
No human is illegal. We fought for DACA and we won it. And we will protect it at any cost.
An example of how awareness of the problem is necessary, but it is insufficient, and that only action creates an attentional window that can be leveraged to build movements for change. From 2019 to 2020, I launched a forensic asylum program in Matamoros as the director of medical initiatives of Project Lifeline, where thousands of families spent months to years after being enrolled into the Trump administration policy of the migrant protection protocols, which we heard about earlier. And many of us actually more appropriately referred to this policy as the migrant persecution protocols. Physicians for Human Rights and Lawyers for Good Government, as well as Justice for Our Neighbors, were nonprofit partners of Project Lifeline in this work to mitigate the immense harm by the US government. Apart from legal and medical legal efforts, dozens of nonprofits were involved in providing direct medical and mental health relief, housing, food, and education in Matamoros. In 2021, the Biden administration is allowing for this inhumane policy to be continued, illustrating the fact that the dangers of government as perpetrator are not tied to a particular ideology or to a particular political party. There are many implicitly anti-immigrant policies that have been very problematic as well. In Texas, I was part of a group of volunteer translators and interpreters made to stand 100 feet from the entrance of a polling location in order to offer our services to voters. The rationale we were given was that we could be electioneering, which can only be done 100 feet from the polling entrance. It did not matter that we were sworn in as assistants and that we were not to engage in any kind of that activity by law, since the English-speaking polling judges couldn't discern what we were saying. We found in 2018 that the elected county clerk in charge of elections was the arbiter of whether and how limited English proficiency voters exercise their right to vote. There is a robust and growing literature on the relationship between individual health, the health of our communities, and the health of our democracy. Failure to make voting accessible to limited English proficiency voters correlates with the poorer health outcomes for these communities. In early 2021, physicians began publicly denouncing the continued use of Title 42, in some ways a functional extension of the MPP, which is also being continued, both initiated by Trump. Title 42 provides public health rationale, as we learned earlier during COVID, to bar asylum seekers from legal entry into the US. For most of this pandemic, we have allowed US citizens and other residents of the United States to move about freely in this country for business and leisure. And yet we claim that the risk of COVID is sufficient to not deny immigrants their legal claim to asylum here. Like MPP, we've also continued Title 42 under Biden. In 2017, when I showed up at my local school board meeting to educate trustees about county, state, and federal anti-immigrant policies and the value of empowering nearly half of our families in the district who are either Latinx or Asian American with information on how to navigate interactions with law enforcement and ICE, my efforts were politely dismissed. Over the next several years, I realized that the advocacy I was doing was powerful in building awareness of the harms and community strength to demand change. But if the policymakers and the executives do not hear the appeals, the leadership needs to be replaced. Thankfully, in a democracy, we have that choice until we don't. In 2019, I discovered that we had 3 of 7 school board seats up for re-election with no challengers. And while I had no ambition to run for office, I did so to ensure that our community did have a choice, to invest in the political education and organizing of our community where that was lacking, and it was lacking, and to change the narrative around school board policy as something that impacted whole child health and the health of our school communities. While I lost this election, the narrative we advanced stuck, and the youth-led organizing that we initiated grew thereafter. By 2020, something became abundantly clear in this once-in-a-century pandemic that has resulted in millions of lives avoidably lost across the globe. A combination of leaders ignorant of the intersecting public health issues, housing, transportation, education, poverty, racialized health disparities, and unscrupulous in their political motives, and social media platforms that algorithmically amplify disinformation for the attention it holds and monetizes have been the cause for the devastation that we have witnessed over the last 18 months. With the patients who we lost in unthinkable numbers and our own growing ire for the for-profit healthcare model that has extracted, exploited, exposed, and silenced our rightful outrage, physicians who understand how the dots connect between the health and dignity of all people are perfectly positioned to transform our democracy, to eliminate the harms of present systems that we are constantly made to chase. Here is the origin story of a vehicle by which we are realizing this political change.
Doctors in Politics is an organization that was started by a group of doctors who realized that in the midst of the COVID pandemic, our hospital organizations, our medical societies, and our government had no plan in which to address this issue. Doctors have gotten tired of watching the worst political decision-making happen and the destruction of a profession we really love. My name is Asylee. I'm trained in family medicine and psychiatry. I chose to specialize in older adult mental health. People would get hospitalized and they would get better for 3, 4, 5 days after treatment. And then they would get warehoused in hospitals because there was nowhere to send them. They had gotten kicked out, or they had gotten priced out, or they had been homeless, and there was nowhere to send them. Nowhere safe. Literally, I'm like, you're telling me that you want me to kick older adults into the streets? And they're like, well, maybe not that, but they can't stay here. I made the decision in the midst of the COVID pandemic, and I told people what we should do is run 50 doctors across the country in 2022. And what was shocking is how many doctors were like, yeah, we should do that. So this group of doctors who'd never met each other who were sick of the way things were being done from all of these different specialties came together to create Doctors in Politics. And in April, we launched our efforts, and within a short period of time, ended up in the New York Times and on NPR. This moment has shown doctors it cannot be the same. When we talk about health as doctors, we are talking about more than just health insurance. All of those things that go into that, housing, environment, gun violence, all of those things talk about what is the environment for you to be healthy. Regardless if you're Republican or Democrat, regardless of race, gender, sexual orientation, who does not want to reach their full potential? Doctors just want to make sure that that's possible. We want to make the laws so that can happen for everyone. No matter where you live in the United States, no matter who you are, if you live here, that should be a guarantee. The benefit of the patient-doctor relationship is they tell us things they would never tell anyone else. So we have insight into things that no one else has. Things that they have not shared with their family, things that they are only sharing with us because they believe we can help them. Doctors are taught to be agreeable, to find compromise, to find solution. It turns out that disagreeability has really no other, it's not an asset anywhere else other than business and law. And those are the people who go into politics. So the reason why we have this crazy bipartisanship is, of course, the people that are there are rewarded for disagreeability. And so what I care about is putting doctors into office who can collaborate, look at data, find solutions, come up with ideas. Doctors have never organized like this before. This is new to us. Organizing to win political power is new to doctors. We have done advocacy groups, but really going for seats of power, changing the conversation is new. The person we are waiting for is us. It's not someone else. We have been waiting for us. To help our patients, we have been waiting for us. It's us. And if we don't come together, if we do not organize, if we do not pull our resources together, right? No one is coming to save us. They didn't come to save us in the pandemic. They're not going to save us now.
So in our inaugural cohort, I wanted to showcase 3 candidates. These were from 2020 for whom their advocacy in immigration and their identity as immigrants has informed their leadership as policymakers. Dr. Eve Kreef is the first of these. She found family separation during the Trump administration horrifying and organized 7 to 8 vigils in her community, rallies as well, to demand accountability and to build public awareness around this problem. She wrote letters and op-eds, and prior to family separation, she admits that she was not at all involved in this area. In 2021, Dr. Kreef ran for the Harborfield Central School District School Board, and she won. Her work has motivated her advocacy for undocumented students and families in her community, many of whom are recent asylum seekers. She states specifically that the students often need additional emotional support. She asks questions of the school district of how they can provide trauma-informed care, where children often are without one or both parents, with one parent or both living in a different country, or not knowing one or both parents. The concerns of school board members have to be addressed by their superintendent, and Dr. Kreef leverages this in order to ensure that specific resources are offered to these families to help them navigate distinct challenges. Equity in language access to educational opportunities, technology, connection to social services post-graduation, pathways to job training and jobs is a priority. And this is also as a function of her experience doing this kind of advocacy work. She says that if nobody cares about this, the schools do their bare minimum as required by the state. So she is the voices of these families on that board.
Dr. Michelle Au is the next person I wanted to profile briefly, and she is a she is a first generation Asian American woman who is the first Asian American woman to serve on the Georgia State Senate. Her district has a very large immigrant population. She knows that disentangling the work of immigration enforcement and law enforcement in policies like 287G agreements is really important to her constituents. These agreements really do prevent them from having a safer community because they're worried about basically having to engage with law enforcement. With immigration if they report anything to law enforcement. So just as an example of one of the things she's done in the last session of the state legislature, she motivated by the Atlanta shootings, if you guys remember, in March of 2020 or 2021, I guess. A group of Asian American legislators, among other things, tried to increase language access to translation with officers of the peace. Our third candidate, he was a candidate for Congress here, is Dr. Pratesh Gandhi, who did not win his congressional seat, but was arguably a win for the broader goal that we have in Doctors in Politics for changing the narrative and driving compassionate and evidence-based policy in appointed positions. So Dr. Gandhi now serves as the Biden-appointed Chief Medical Officer of DHS. He's probably one of the more contentious people that I'm profiling here. For those of us who are interested in global health, as he perpetuates a system that does generate these harms that we are then made to chase, as I've framed it. He's exquisitely aware of this conundrum, and he demands that his colleagues keep him apprised of what is happening on the ground, as that eludes him. He's no longer a practitioner or advocate on the ground, and he expects to be held accountable. So I want you to consider this critically. In March of 2021, and this is information that he provided to me, with a large influx of unaccompanied minors, unlike the prior presidential administration, Dr. Gandhi was able to work with Biden to lead a team of physicians who did clinical rounds to ensure that the immediate health and safety of these children was maintained. In Del Rio, just a few weeks ago, he was able to mobilize 150 clinicians into a makeshift arrangement, set up water and latrines with his background in complex humanitarian emergencies, and to implement SPEAR standards. While Biden and Mayorkas may have received appropriately scathing feedback on the massive swift deportation of these largely Haitian immigrants, it's hard to argue that the immediate health needs of these families were unaddressed by Dr. Gandhi's efforts. With refugees in Afghanistan, pushing through a mandatory measles vaccination campaign was important for averting a major measles outbreak that would compound the many challenges that these families already face. Oops. Okay, sorry about that. So I just wanted to show here a couple of the stats that we have on the doctors who we've recruited to run for public office with our political action committee. And I wanted to say first that crisis creates moments of clarity and potential for transformation. And the answers to our existential questions often lie in that crisis. So here right now, we've started this political action committee, and we've recruited over 100 doctors to run for public office. Over 45% of them are doctors who have decided to run because of the lack of mask mandates. So these are very local offices that they're running for. Local and state. 24% of the physicians who are engaging with us are people of color. 71 of the doctors who have decided to run for office of the slightly over 100 are women as well. So this is the moment that we're in. If you guys recognize this, it's from Del Rio, the Black migrants there just a month ago being corralled like animals and swiftly deported to a country that many of them fled a long time ago, or some of them are not even from. And here we have our colleagues in medicine who were not personally untouched by racialized systems, with a disproportionate number of us, healthcare workers who died being immigrants, and also people of color. So I wanted to leave you with this quote by Arundhati Roy. You all may have read this when it first came out in the Financial Times, but I think it's very poignant. What is this thing that has happened to us? It's a virus, yes. In and of itself, it holds no moral weight, but it is definitely more than a virus. Some believe it's God's way of bringing us to our senses. Other that it's a Chinese conspiracy to take over the world. Whatever it is, coronavirus has made the mighty kneel and brought the world to a halt like nothing else could. Our minds are still racing back and forth, longing to return to normality, trying to stitch our future to our past, and refusing to acknowledge the rupture. But the rupture exists, And in the midst of this terrible despair, it offers a chance to rethink the doomsday machine we have built for ourselves. Nothing could be worse than a return to normality. Historically, pandemics have forced humans to break with the past and imagine their world anew. This is no different. It is a portal, a gateway between the one world and the next. We can choose to walk through it, dragging the carcasses of our prejudice and hatred, our avarice, our data banks and dead ideas, our dead rivers and smoky skies behind us, or we can walk through lightly, with little luggage, ready to imagine another world and ready to fight for it. Thank you very much.
Questions from participants? Comments? Oh, Olga?
Yes. Well, thank you so much for this presentation. I was going to ask something in the past presentation, but it ties very clear. And I think the answer, you give me the answer to the question I had, which was the sense of agency that doctors can have amidst, like, in the face of these constraints, political constraints. But you have shown a very clear example of all the work that they are doing. And I just was thinking, which are the challenges as well, because Tom's presentation was focused on how they feel and preparedness for what they found in the shelters, but then turning into another field, which is politics, which is a big field full of new information for doctors. So which are the challenges, but also the interdisciplinary approaches, other specialists supporting the movement, lawyers, or other people more like trained in politics that is being part of this movement as well.
Yeah, so I mean, there's already a huge political infrastructure, right, that helps to recruit and run people for political office. Lawyers vote much more than doctors do. Lawyers run for political office and occupy political office much more than doctors do. And we are leveraging that existing infrastructure. So Doctors in Politics, for instance, has partnered at the very beginning of our existence with 314 Action and with Run for Something. These are political action committees and nonprofit political organizations in order to train our doctors to successfully run campaigns and then to successfully govern once they're in office. So we're definitely leveraging what's there of people who are kind of ideologically like-minded, right? We think about things in terms of health, right? All policy is health policy to us. And so anybody who's on the same page, then we try to ally with them because they've already been in the space and can help to provide us some guidance. Physicians are bad about being politically engaged. I think that a lot of us feel that our service to society is through the care that we provide to our patients, and that is exhausting in and of itself. And so as discussed before, it's hard to ask someone then to above and beyond that to be engaged politically, but this is our social responsibility, right? And I think that if we think of it, if we reframe and think of it as like, that's just part of what we do as physicians because it aids in providing good care to patients to ensure that all of those social determinants of health are appropriately addressed, then I think it's a better sell. But yeah, I mean, right now, only 40%, somewhere around 40% of physicians who are eligible to vote even vote. So now getting them to run for office, it's like, I mean, it's kind of some people think that we're just out of our minds, right? But it's apparently resonating because there are physicians who have started showing up at school board meetings because of the COVID mask mandate bans and other things having to do with COVID. And they're beginning to realize that the way that power is handled in the community is not in service to the people that they serve as their patients, right? And also they suffer from it because physicians who have, for instance, spoken out against their hospital systems during the pandemic or for-profit care and what that's looked like for us in trying to manage this pandemic, they have been penalized, right? There's been retribution against those physicians. So there's a lot of energy now, I think, for people who, are very angry to put that somewhere. And this is a really productive place to put that energy.
Yeah, thank you so much for your talk. And thank you for Doctors in Politics. It's very important work. So my question is that I sometimes teach medical students on the social and political determinants of health and ultimately arguing for the role of advocacy for their role as future doctors. And not all of the time, but I would say probably once in every classroom setting, there is a student who kind of pushes back and says, well, this is not the doctor's place. This isn't my responsibility as a doctor. My role is to focus on the clinic within the four walls and not so much out in the community. And so I was just wondering, you know, obviously you've been talking a lot about the role and the importance of it. And so in many ways you've already answered it, but what would you say? I mean, how often do you come across that kind of mentality amongst students or doctors? And then what would you kind of like push back on that?
Yeah, I think it's very common, unfortunately. So like we're kind of socialized in medicine to believe that you're right, that exactly what you said, that our role is to take care of patients in, you know, in the exam room, and that we shouldn't be bringing our political ideas to any of the conversations that we have. But like we're inherently political beings, right? And everything that comes to bear on the health and well-being of our patients actually is impacted by policy, right? Which politics has, you know, has influence over. And so I think now actually at some of the, we have, there's an organization called Future Doctors in Politics, and it's a group of medical students out of Harvard, and they were kind of inspired by our political action committee work, and so they created this other organization that's a C4 nonprofit. They're trying to change the way these conversations are being had at the medical school level, so trying to kind of upstream to make sure that people who are in medical training understand that that's actually a part of what they are responsible for doing when they go out into practice.
Okay, thank you very much.